Good afternoon, everybody. I'm an ophthalmologist from London. This is not something which has happened overnight. We've been thinking about this for near on 10 years. I started implanting previous technologies for AMD, such as the VIP and Revolution, back in 2005, 2006. And I trained starting with extracapsular procedures. So VIP and Revolution were large incisions, complicated surgery, had to perform an iridotomy, and we were placing very large PMMA lenses within the capsular bag in the anterior chamber. This is what originally prompted me to think of a solution. We were carrying out surgery which lasted 45 minutes, and when we were doing a phaco in 5. And I thought there must be a way where we can use technology to move to small incisions, foldable optics, and improve the optics. And that's how IolAMD was originally conceived. The original technology is putting two lenses into the eye. Essentially, we rely on the anatomy of the eye for alignment of these two lenses. In large eyes, these two lenses were further apart. The misalignment to create the prism was unpredictable, and it was actually surprising how many patients actually had a reasonably good visual outcome despite all this unpredictability. And that's what we were trying to improve with IolAMD, the tolerance within the lens. We realized that a double lens was never going to have a significant uptake amongst cataract surgeons, and we had to move to a simpler technology, as Professor Artal said. And it's funny how things work out. We start looking and researching into one aspect, and we end up discovering something else. And what we realized we could do was improve the image laterally on the macula instead of physically deviating it there. So the two lenses are essentially now a single optic. The original design actually won the award for Innovation of the Year in 2014 by the Ophthalmologist magazine. And the Eyemax mono, as we have called it, is single piece, hydrophobic acrylic, goes through a 2.5mm incision with a 6mm optic. So this is an implant we are all familiar with, and it's a surgical technique which we do not need to change what we are already doing. Now, I don't want to dwell on the anatomy and the physiology. We're all familiar with a lot of this information. At the center of the fovea, we have a very high cone density, 200,000 per square millimeter. And as we move further away from the center, it declines very rapidly, as we know. So it's not possible, as Professor Artal has already said, to have 20/20 vision at 5 or 10 degrees. We appreciate that. But the image at that position that the patient with AMD using is not optimal. It's a blurred image, as Professor Artal has already explained. And all we're trying to do really is optimize the potential at that eccentric area of macula. So, coming back to two concepts which we already accept for the management of AMD, we give patients glasses, external glasses with prisms, to deviate the image from the fovea to wherever they're using as their preferred retinal locus. And older technologies such as the VIP, the Revolution, and the IolAMD have essentially used that concept. The other thing we accept is magnification helps patients with AMD. And these technologies I've already mentioned, plus others such as IMT, utilize this phenomenon. Now, a standard monofocal lens, the optics are designed to provide a very high contrast, good quality picture at the fovea. And as an AMD patient, once that area is damaged, starts using an eccentric or peripheral area of macula, the image quality there is much, much poorer. So as you can see there, the first circle is 5 degrees, and the second is 10 degrees in an average eye. So a patient having a PRL at 5 or 10 degrees is using a much poorer image than the one at the fovea. A prism would deviate the image from the fovea to wherever that individual PRL is. Okay, that's how they work. Now, what the Eyemax does is it doesn't deviate the image, it optically improves the image at that eccentric macula. Okay? And it doesn't improve it in just one area, it improves it 360 degrees as you go out from the center of the fovea. Okay, so I want to be very clear about this. This is not a telescope. Okay? This is a whole new sort of optical lens which hasn't really existed before, and we've called it an extended macular lens for this reason. If you aim for emmetropia, there is no magnification. The only effect the patient will have is the improved image quality at that peripheral macula that they are using. The optics have also been designed so that if you leave the patient modestly hypermetropic between +2 and +3, you can, with the external glasses, introduce some magnification. And this magnification has been calculated to be about 10% for distance and about 20% for reading. So just to summarize, a patient who's using eccentric fixation with a standard monofocal lens at 5 degrees or 10 degrees or wherever they may be, the picture above shows the image they would be using. And with the Eyemax mono, it shows the image below, which they are now using to optimize their vision. And this extends all the way out to 10 degrees. Now, this is just a reference example from simulations we've done to show the magnification. And the magnification is modest. It's only 10% for distance and 20% for reading. And it's at the surgeon's discretion if you want magnification or not. If you aim for emmetropia, there is no magnification. If you aim for modest hypermetropia, you can introduce magnification. So just to summarize again, the Eyemax mono works similar to a prism, but it's not a prism. A prism deviates the image to a particular PRL. The Eyemax mono uses very sophisticated optics to enhance the image at that peripheral area of the macula. Okay. Now, this has other benefits because, as we know, the AMD is going to progress, and subsequently, if the AMD progresses into the area which is being used as the PRL, the patient will shift their PRL. And wherever they shift their PRL to, the image there will always be optimized to achieve the maximum capacity that's possible from that area of eccentric macula. Now, the lens is in over 2,000 eyes in over 13 countries now, and it's been used in a wide spectrum of macular disease, not just macular degeneration, and inherited diseases and also macular holes. There are currently about 50 surgeons who are using it regularly, and I suspect in the next month or two it's going to increase by several hundreds. Here is just a very short list of the early adopters. In terms of who is suitable, if you look at the image quality at the fovea, even with the Eyemax mono, you will realize that it's almost as good as a standard monofocal. So ultimately, you could use this lens as, or shall I say, in place of a standard monofocal lens, even in patients with the visual potential to have 20/20 vision, because that outcome will be pretty much the same. Now, that's not what we are recommending here, but it's good to know that in your patients, the worst case scenario is the vision will be as though you had implanted a monofocal lens. However, in patients who do have an eccentric fixation, the potential is obviously much greater. Now, in terms of defining who does better, there's still a lot of work to do, but we believe from the data we have, the best patients to start surgery are those in the intermediate category with vision between about 0.5 and 0.1. You can use it in patients who are worse than this and better, but that's the patients I would suggest. The phakic version of the lens now comes preloaded. I can play the video. Where is it? It will go through a 2.2, but our suggestion is probably a 2.5, 2.6 is just easier. You place the cartridge with the lens, you can just see it there, in BSS for about 60 seconds at room temperature. You take it out, remove the spacer, add a few more drops of BSS, and then you just close the cartridge and you just inject. And just like any preloaded system, you just have to be careful you don't retract the plunger and inject again, and you just inject slowly. So this is a lens we are very familiar with, hydrophobic acrylic, and how it behaves within the eye. So I don't really need to go into that in any more detail. Now, the older lens, the IolAMD, has several publications, albeit small case studies. But what I really want to tell you about is the study that was just published recently in the European Journal of Ophthalmology. And this is 244 consecutive cases that we performed at the London Eye Hospital. And I would like to say they were all mine, but it was actually 4 surgeons, of which I probably performed the least, actually. We looked at safety and we looked at efficacy. And as Professor Hengler has already covered, visual acuities at a 3-month average follow-up improved for distance 18 letters ETDRS, and for near 24 letters ETDRS. In terms of safety, targeted outcomes, we were quite close to what you'd expect. Specular also only a very modest decrease I would expect with the monofocal design, and the same with IOP. Importantly, not a single patient lost vision at 3 months follow-up, and there were no intraoperative or postoperative complications. Now, I'm not going to dwell on these slides, but there is a lot more data out there. We have 20 eyes from Spain that you've already heard about. Dr. Dyer will talk about another 50 eyes or so. And we've looked at other aspects of visual function in terms of reading speed, visual fields, microperimetry, and these are all available as abstracts here at Lisbon or awaiting publication. Now, one common question which is asked is, that's great that you get a nice and significant improvement in vision, but what component of this improvement can you attribute to removing the cataract? And in answer to this, we essentially ask people to have a look at this paper. Essentially, it's a meta-analysis and systematic review of patients who have undergone cataract surgery who have AMD. And they found that on average, the improvement in vision is 6 to 7.5 letters of ETDRS. So obviously, with the data we have and from other centres around Europe, we have at least 2 to 3-fold more improvements in vision compared to this. I'll just leave you with this final slide, which is the same data that I've just presented here, published recently in the EGO. And I'll introduce my fellow colleagues here to present some of their clinical results. Thank you very much.